Thank you for the introduction, Des, and thank you to everyone for spending your time with us this afternoon on a topic that I'm sure you're well aware by now we are very, very passionate about. So we're going to be discussing the pediatric liver emergency, and it's interesting to see that actually this encompasses both acute and cholestatic liver disease. So it's a nice topic that umbrellas everything we're going to be talking about today. Just a brief introduction for Fran and I, Fran, your computer is not moving. Sorry about this. Okay. So our disclosures, none of us have any affiliation with any pharmaceutical companies, and we have no other disclosures to present. An introduction to where we all at the current moment are working, along with Des as part of a permanent complement team. We are a non-profit foundation. We are a private state collaboration, which means that we also perform transplants on state patients. And at the moment, we are comprised of a permanent complement of pediatric gastroenterologists, pediatric intensivists, and transplant surgeons who are all salaried. In addition to a support staff of transplant coordinators, allied health, psychologists, social workers, and we're all overseen by unit managers. And we just like to bring to the fore that while it takes a village to raise a child, it also actually takes a village to bring a child through chronic liver disease and out the other side of transplant. So the pediatric liver emergency encompasses basically 4 elements. So the first is the diagnostic emergency, which is the infant with liver disease, which we will address later. The second is pediatric acute liver failure, which we're actually going to concentrate on in today's talk. And then variceal bleeding and metabolic encephalopathy, which are actually subsets to both the diagnostic emergency and the pediatric acute liver failure, which we won't be addressing today in particular. So pediatric acute liver failure is basically our topic of passion and interest, and something that we'd like to bring to everyone's attention and educate. So what exactly is pediatric acute liver failure? So it's rapid onset, severe disease that progresses quickly. And this cannot be kind of brought to the fore more. It's incredibly rapidly moving. It accounts for 12.5% of all transplants performed and is an important cause of mortality. And the management challenges that a team is faced with is A, determining the cause, B, supportive management of the patient, and 3, timely transfer of the patient. And we'd like to cover these elements today. So of absolute importance is the definition. So there's been a commonality to definition, which has now been shared by both everyone in America, the European Union, and basically it has stemmed to a common definition. And this is from the Pediatric Acute Liver Failure Study Group, which is actually American-based, but it's shared internationally. And it's acute onset of liver disease without evidence of chronic liver disease, biochemical evidence of severe liver injury, a coagulopathy not corrected by vitamin K, in the presence of an INR more than 1.5 with evidence of hepatic encephalopathy, or an INR more than 2 with or without encephalopathy. Sounds simple enough, but there are some problems in terms of interpreting this definition, one of which is without evidence of chronic liver disease. How can we exclude features of chronic liver disease? We can look on examination, which presents with growth failure, any kind of dysmorphic features, a spleen, so a splenomegaly, which would suggest portal hypertension, ascites, although it can be present in the context of acute liver failure as well, chronic features such as clubbing, a rachitic rosary, xanthomas, and varices or spider angiomas are much more specific. Peripheral edema, again, is something that can be present in an acute phase as well. So although they are suggestive of chronicity, it can be very difficult to identify the presence of a chronic underlying disease. The biggest kind of challenge, though, is the definition of encephalopathy. And this is important because it's incredibly contentious in children. What is the definition of encephalopathy? And I wanted to bring to everyone's attention the fact that stage 1 and stage 2, or early encephalopathy, is actually ascribed to a mental status where a child is inconsolably crying, has sleep reversal, or has inattention to task. And this is in the age group of under 4, combined with either normal or hyperreflexic reflexes. So this, you can understand, can actually be attributed to behavioral changes because a child has been admitted, or can be attributed to behavioral changes because the child is sick. So it can be incredibly difficult to identify the presence of early encephalopathy in a child under the age of 4 years. What about over the age of 4 years? So if you're looking at a child beyond that age, they get mood swings, euphoria, depression, confusion, slowness, blunted affect, untidiness, slurred speech, disordered sleep. So a lot of these are missed in the early stages because of the fact that these are all attributed to illness as opposed to encephalopathy. So it's important when you are suspecting any kind of liver disease to look carefully at the behavior and the mindset of the child and make sure that you're not missing either a stage 1 or stage 2 encephalopathy. And of course, coagulopathy and encephalopathy are the mainstay of the definition. So let's just go into a little bit about the coagulopathy and encephalopathy of acute liver failure. So the coagulopathy is balanced loss. It's loss of both pro and anticoagulants. It represents a loss of synthetic function rather than a bleeding tendency. And this is important. The risk of thrombosis actually outweighs the risk of bleeding, with bleeding only occurring in 5% of patients and in less than 1% intracranial. Overtransfusion increases the risk of both bleeding and thrombosis, and this is the basis for limited use of product. Encephalopathy does not relate at all to the coagulopathy. In the pediatric acute liver failure study group, 25% with grade 3 and 4 encephalopathy only had a mild coagulopathy, so an INR of less than 2. And importantly, these patients carry the highest rate of mortality. So it's important when you're assessing your patient who is suspected to be in acute liver failure to look closely at both your coagulopathy and your encephalopathy. So how do we determine etiology? So looking at the pediatric acute liver failure study group, which came out of America, they looked at 1,144 patients with acute liver failure, and their dominant pathology was indeterminate. And we'll go into a little bit more detail about that particular cause later. Their second cause was paracetamol, and their third was autoimmune related pathology. If you look at our experience, you'll find that we actually don't have a lot of data. And this is because we don't have like a standard registry, and our results are not well documented in terms of patients who both present with acute liver failure who recover, or those who are transplanted, or those who basically demise. So what we're working with is limited data. So what I can report is that this study came out of Tiger Bird Children's Hospital. It looked at patients between January 2009 to December 2013. And you can see the dominant cause of acute liver failure in our setting is viral. And of that, what dominates the picture is hepatitis A. And you can see a distinct kind of picture down the side there that there are quite a few of these patients who actually passed away. If you look at our experience at Donald Gordon, we of course only have experience with those who have been referred to us for transplantation. So we are also looking at a severe subset of disease. But our etiology of acute liver failures we looked at in terms of our patients who have been transplanted also had a dominant viral pathology, with 59% being attributed to a viral cause. And of those, 69% were secondary to hepatitis A. So hepatitis A is definitely the dominant contributor still, as well as other viral pathology. But in terms of looking for an etiology, you can see that there is an extensive list of investigations. Etiology ranges from drugs, toxins, to autoimmune, viral infections like those that dominate our environment, hematological disorders, which now is more falling under the umbrella of immune dysregulation states, metabolic and genetic etiologies, as well as vascular, and then gestational autoimmune disease, which also is actually an immune dysregulation state. So if you look at that, you wonder, where do you begin? And we've come to our institution, we have established a basic investigation chart. And this covers the basic etiologies. So in the event that you have a patient with acute liver failure, there is a high probability that we will request these investigations of you. And you can see we've clustered it into basically general investigations, which includes your FBC, your CMP, your basic viral pathologies like your HIV is under that umbrella, as well as your iron studies, and then your liver function, which includes your factor V, your fibrinogen, your ammonia, your glucose, your INR, your viral pathologies, which, like I say, dominate, toxin elimination as an etiology, autoimmune, and then we've divided our metabolic and genetic into patients who are infants and patients who are older children. And why is it important to establish etiology? Because there are causes which have disease-specific treatment options. And this is just a very brief summary. Tabulates a few of them, such as tyrosinemia with nitazoxanide and paracetamol with N-acetylcysteine. And these are all interventions that are available and tests that are readily available and accessible that you can identify a pathology and do a targeted treatment. I said we'd get back to indeterminate, and that's because it's a bit of a complex idea. It's a growing element of acute liver failure. It accounts for 43 to 49% of pediatric acute liver failure in both the American and the European experience. And basically, it is a CD8 intense infiltrate undetected on liver biopsy associated with an elevated soluble IL-2. And at the moment, the hypothesis is that it is undiagnosed metabolic or genetic causes. It perhaps may be secondary to drug-induced etiology, unknown or undetected viral causes, or a disorder of immune dysregulation. And the important thing is that in identifying these patients, they have a very poor native liver survival. So a lot more of these patients both demise and go on to requiring liver transplantation. But acute liver failure is not static, it's a course. And this is where transplant comes to play and where recovery also plays a role. And you can see that at any point in time, we interrupt the course of acute liver failure. And we are actually unable to confidently report the course of liver failure because of the fact that we do interrupt it with liver failure. And what we're trying to do at this point in time is we're trying to identify patients who are going towards the demise section and avoid transplanting patients who are moving towards the recovery component of the course. And this seems simple, but it's actually a very complex process. Just to put into kind of a setting, I'm going to just show you a few of the reports from international experience. So this is from a European experience. So this is a report on patients transplanted for acute liver failure, patients between the age of 0 to 2 years old. And you can see that they transplant 8% of patients in that age group for acute liver failure. If you go on, you can see they transplant a larger proportion of patients who are 2 to 18 years old, and that is a 15% experience. So not a large proportion of patients are actually transplanted for acute liver failure in the global setting. If you look at America, between the years of 2008 to 2010, they transplanted 11% of patients, 190 at that time, for acute liver failure. And that has actually dropped to 7.7% of patients in the period of 2018 to 2020. And this is because we are becoming better at medically managing these patients and also at identifying patients who are more likely to survive with their native liver and who are more likely to require urgent intervention and interruption of that course with liver transplantation. If you look at our experience, we have transplanted 34% of patients that have been received at our institution. This is unpublished data. And we have not transplanted, obviously, the other 66%. And the patients who have gone on to transplant have had indicators of severity that have been quite severe. So the majority of our patients that we have received for transplantation have had grade 3 to 4 encephalopathy. Some are on acute dialysis, 19%, 52% are hemodynamically unstable, so they're on inotropic support, and 84% of those patients are on mechanical ventilation at the time that they get transplanted. So you can see that the patients that go on to transplant they're multi-organ dysfunction. Just taking a look at our non-transplanted patients, you can see that the majority do go on to actually demise. And this is coming from our institution, though, where a lot of the patients are referred to us for transplant. And so we are probably introducing a bias towards severity. But what's important to note is that there is an element of patients here who also recover, and that is the dominant course in acute liver failure. Recovery is actually the dominant course. And then if we look at our patients that we transplanted, we have transplanted 32% of the patients received at our institution. And you can see that the majority of those have gone on to recover post-transplant, with only 5 out of 32 having actually demised. And this is actually above international standards. And that is probably linked to the fact that in the international setting, they are transplanting for indeterminate, whereas in our setting, we're actually, majority of our transplant patients are actually for viral etiology. And just to look at the impact of hepatitis, this came out of a study performed in Cape Town. And just to give you an idea of the scope of acute liver failure and how many of these patients we should be seeing and identifying. So during the period of study, they saw 239 patients with hepatitis A, of which only 1.7% had an INR of more than 2, and only one patient of those 4 actually demised. Only 3.8% had an INR of 1.5 to 2, and of those 9 demised. So you can see what we're presenting is actually a small minority of patients, and there must be a gross majority of patients out there that are not being attended to at our institution or not being referred to our center. And in terms of the impact financially and on a hospital, a lot of these patients stay in the hospital for a prolonged period of time. And you can see as the patients become more complicated, the duration of stay is extended. In terms of cost, you can see that these patients have a significant cost affiliation with their stays in hospital. So the burden of disease is significant. So the important part of this whole equation is, when do you transfer a patient? When do you pick up the phone and notify a pediatric hepatologist or gastroenterologist? And at this point in time, the growing consensus is as soon as possible. So if your patient meets POLF criteria, that it is exactly at that point that you contact or transfer that patient to an experienced pediatric liver transplant center. And this is supported in multiple publications. In fact, the growing trend is towards admitting the patient directly to a liver transplant center to initiate baseline evaluation within 48 hours of presentation. So the answer is that as soon as a patient has been determined to be in acute liver failure, they should be admitted to a pediatric liver transplant center as early in the course as possible, because it is such a rapidly progressive and unpredictable disease. They have shown better outcomes in those transferred before hepatic encephalopathy has evolved, and the centers are now actually favoring listing during workup and ongoing intensive care treatment within the first 24 to 48 hours. With time to listing on the pediatric acute liver failure study group after enrollment being 1 day, which means that within 1 day of identifying a patient in acute liver failure, that patient has been transferred to a center with an acute liver failure unit and has actually been enrolled and listed within that 24-hour period. I just wanted to illustrate the need for imminent transfer. So this is a patient that arrived with us in April, and you can see obvious evidence of liver injury, obvious evidence of synthetic dysfunction with an INR of more than 10 and an ammonia of 123. And you might ask yourself, what happened during this course that ended up with the ultimate result of transplant? If you look at those numbers, there's nothing there that says that this patient has changed in any fashion. However, if you look at the clinical scenario, the patient became encephalopathic and required ventilation within 12 hours. Within another 24 hours, the patient began to present with features of raised intracranial pressures. And by the 40 hours, the child was critically ill and had autonomic instability. So you can see that the numbers that we're presented with are not nearly as important as the clinical events that are associated with these numbers. And this is why it is so imperatively important that these patients are in a center in which liver transplant is available, because this disease course is incredibly fast moving. Time to transplant in this particular patient from arrival to on table is 48 hours. So how do you engage us? It's pretty simple. We are available by phone. We are available 24/7. This is the number for our call phone, as well as my personal phone number, as well as our pediatric transplant ward, which is all of which are available 24/7. What I had mentioned that we are a public-state collaboration, and our colleague in Charlotte Kicks is Dr. Wallab, and she also has a team that is available 24/7 to receive patients for transfer. So in terms of interrupting the course, we do have specific therapies available to us. And I just wanted to mention a few of them and also to mention their success. So in Wilson's, there is an acute Wilson's. We perform single pass albumin dialysis and plasmapheresis to remove copper, but this is not actually very successful in terms of prolonging native liver survival. In autoimmune hepatitis, we have steroids, which only shows a 41.4% response. And the role in indeterminate pediatric acute liver failure, which I had mentioned was an immune dysregulation state, has actually not been established. So at this point in time, its only application is in autoimmune hepatitis. Role of plasma exchange is not well established at all. What about one that we all know? What about N-acetylcysteine? Well, we know its benefits in acetaminophen associated liver failure, but in non-acetaminophen liver failure, it's very controversial, with no survival advantage having been demonstrated. And actually a survival, a problem has been affiliated with patients under the age of 2. So it's highly recommended that non-acetaminophen liver failure patients under the age of 2, you do not put these patients on N-acetylcysteine. High volume hemofiltration has been implemented in a small subset of patients with encephalopathy grade greater than 2, hemodynamic instability. These patients have shown an improvement in both their blood pressures, their renal function, and their encephalopathy, but not in the survival outcomes because this group is too small to have that interpreted. CVVHD and plasma exchange has been shown to decrease the catecholamine index, which the inflammatory cascade is suspected to be an important part of the whole process behind acute liver failure. But again, it's the number of patients in these studies is too small, so we need to collaborate our evidence to see if this has any kind of survival benefit. And extracorporeal liver support, such as our MARS systems, are also, we do not have any recommendation available based on current available evidence. But what do we have? And this has shown a survival benefit, and an important one is our supportive management. At this point, I'm going to hand over to my colleague, Dr. Grace.
Good afternoon, early evening, everyone. Thank you so much, Des, for that very kind introduction. Not that great by any means, but I am loved, clearly. So yeah, it's a pleasure speaking to you this afternoon. And I will speak on something that actually, as a surgeon, I've learned mostly through observation. So the very qualified intensivists and hepatologists are free to correct me at any point. But yes, supportive management is very important. And the goal of supportive management in these patients mainly surrounds treating the extrahepatic dysfunction. And the idea is to support life, in other words, all the other organs that's gone, until the liver has had a chance to either regenerate or declare itself as being irreparable and therefore requiring transplantation. And then there are therapies which actively promote liver regeneration. So what do we need to do? We need to have systemic support of essentially most organ systems, because acute liver failure is essentially, in the end, a multi-organ failure disease. So airway and respiratory system support is very important. You need to actively manage fluids, electrolytes, and the metabolic status of the patient. The renal system will require some forms of support often. There are cardiovascular changes that you will need to manage. Very importantly, neurological function needs to be protected and supported, because essentially when patients die, they die from cerebral edema and coning often. The coagulation system needs to be observed more than supported, and I'll go into that a little bit later. Secondary infections needs to be prevented. The child will need some form of nutrition, especially if you've got the child in your unit for a couple of days. And then there are some cause-specific treatments that Riza has alluded to. So looking at the airway and respiratory support, these children are at risk of both ARDS and a TRALI. We are very wary of giving these kids lots of blood products because of this risk. And you will have to actively monitor the saturation, PO2s, PaCO2s, and pHs. Mechanical ventilation often becomes indicated for airway protection in children with a grade 3 or 4 encephalopathy. And in a neuroprotective fashion, children are very agitated, even with low encephalopathy rates, may require sedation, which then leads to the requirement for intubation. You employ lung protective ventilation as often as possible, low tidal volumes, low PEEPs. And if you do require paralysis, atrachurium is preferred since it's not dependent on hepatic elimination. And obviously the basic principles apply: prevent aspiration, nurse the child head up, and avoid dysynchrony on the vent. So keep sedated or paralyzed as indicated, but you do not want the child fighting on the vent and raising the intracranial pressure more. What about fluids and electrolytes? These children are very prone to sodium derangements. Other things that you may encounter would include hypokalemias, hypophosphatemias. This often happens with attempts at liver regeneration and lots of ATP being produced within the hepatocytes. That phosphate gets sucked up out of the system, and you will have to actively replace that, as well as hypocalcemia can become an issue. Hypoglycemia, I know that's not an electrolyte per se, but it is just on that list to actively monitor. Very common in a burnt out liver, and obviously not great for the brain. So actively monitoring glucose is critical in these patients and supporting it as required. Metabolic acidosis often follows in the kids that are very ill. And acute kidney injury is common. And this is because you get intrarenal vasoconstriction with decreased renal perfusion. Often you've got other compounding factors such as drug toxicity, children being behind on fluid or septic. And they typically recover as the liver function improves or post-transplantation, those kidneys will come around, but you may need to support them up until that point of recovery or transplantation. So what are our goals? Euvolemia, essentially. You don't want to overhydrate the child. This will give you pulmonary and peripheral edema and ascites, and will worsen your cerebral edema. So definitely not to just go ad lib with the fluid, but in the same vein, underhydration is as bad. That may tip your kidneys over properly into an ATM. That can worsen your encephalopathy and hypotension. So definitely not what we want either. So aim for euvolemia. We have to protect cerebral perfusion and keep that cerebral perfusion pressure adequate. And generally we give about 80% of the maintenance, and beware large fluid boluses. Continuously monitor the child and do fine tuning of that fluid maintenance. Obviously we aim for normal glycemia. You may end up having to give a dextrose infusion of 5 to 10% of dextrose just to keep the child normal glycemic, and that would have to go in through central access. Electrolytes, like I've mentioned, phosphates, very important. Actually, when the phosphate drops, that's a good indicator that that liver has got a chance of regenerating. When the phosphate stays high, often that's a poor sign that this liver is burnt out and it's not making any attempt at regeneration. So if it's low, replace it, and that will help support liver regeneration. Maintain your sodiums at daily maintenance requirements, and then monitor that on your gases and on formal testing. We know that a hyponatremic state could help reduce raised intracranial pressure, but sustained hyponatremia should be avoided. That's definitely not a good thing. What about the kidneys? So like I've mentioned, acute kidney injury is very common. CVVHD is often employed in our unit. It helps a lot in managing these children metabolically, especially when they're in an advanced state of decompensation. It helps you to control the metabolic acidosis and fluid overload. It often helps you decrease your iron and drug requirements. And then there's this issue of ammonia levels. There is good evidence in children that dialyzing ammonia off is neuroprotective. There's less evidence for it in the adult population, although we often veer in that direction in fulminant adults as well. So there's a big role for CBVHD, and you should have a low tolerance for it. And just as a side, if you're going to use regional citrate instead of heparin as an anticoagulation, beware hypocalcemia and acidosis. So initiate continuous renal replacement therapy early if the child's oliguric, very overloaded, patients with severe electrolyte abnormalities that are difficult to correct, those acidotic children, and then hyperammonemia of more than 150. You should probably have that child on dialysis. The cardiovascular system is often hyperdynamic, and that's because you've got peripheral vasodilatation, which decreases your SVR and therefore leaves you with low mean arterial pressures. So you will have to actively monitor the cardiovascular system through the usual measures. And then you could also employ mixed venous oxygen saturation, stroke volume variation, pulse pressure variation in patients on inotropes, just to help guide you on where you are in terms of perfusion. So very important to have the patient fluid replete, and only then start your inotrope. That's the normal basic principle. Noradrenaline is our inotrope of choice. If you have access to it, it's first choice. And low-dose vasopressin may be considered if your NORAD requirements start to escalate, just to tighten that patient up peripherally and help to deal with that vasodilatation that goes hand in hand with liver failure. So it's an important thing just to note at the back of your head that if you have to start escalating your organ requirement, your organ support very quickly, all of a sudden, it may indicate that you're sitting with a child with a dead toxic liver. And we have in the past done a hepatectomy on a child like that, knowing that we've got a liver en route. And that often turn a lot of these instability markers around in just getting rid of that massive toxic tissue. But obviously you would need to have access to a graft imminently. So either have a living donor on the table or have a very sure organ offer en route. And we've done that in the past before. Remember that a relative adrenal insufficiency is not unlikely if your patient's inotrope unresponsive, so consider supporting with steroid. What about the neurological monitoring and support? So in the end, this is what we all fear: raised intracranial pressure, cerebral edema, coning, and then brain death. So hepatic encephalopathy and raised ICPs are very common in acute liver failure. And it's a whole host of mediators responsible for this. A lot of them are being studied. We know a lot more relatively about ammonia. We know that high ammonia levels increases intracellular osmolarity in the astrocytes and lead to cerebral edema and neurotoxic cerebral edema. So you have to monitor this child at very short intervals if they're not already intubated, sedated, and paralyzed. Look at that GCS often and at which stage of hepatic encephalopathy the child is in. Actively monitor the child for sudden raises in ICP. In other words, the kid that becomes bradycardic, dystonic, hypertensive, have a blown pupil, 1 or 2. Those with focal neurological deficits or with seizures, you should be very worried that this child is about to cone. And we would recommend instituting therapy to bring that intracranial pressure down. And once you're a little bit more stable, or if the child does not respond, you might end up doing brainstem testing on that child soon. Another thing to keep an eye on, obviously, would be your glucose levels. Hypoglycemia is very common and could also reduce your GCS. And then when you do an ammonia level, remember that you need a free-flowing blood sample quickly placed on ice to avoid falsely elevated results. And if your ammonia is very high, that child should be on dialysis. What about monitoring? We used to do a lot of invasive ICP monitored with bolts. However, worldwide evidence has now come out to show that there's very little evidence for overall benefit. The risk of intracranial bleeding from placing a bolt or an intracranial pressure monitor is 7%. And we've certainly run into serious trouble with intracranial pressure devices in the past, and we've abandoned that completely now. You could do reverse jugular venous oxygen saturation. However, that's intermittent, it's indirect. And you could give the child the jugular venous thrombosis, which in the setting of a raised ICP is probably not the best idea. We don't, in our unit, employ that regularly. Transcranial Dopplers, we do. However, it is operator dependent, so get it done by someone that you trust, and you would look at a pulsatility index, mean blood flow velocity, and arterial pressure. If your child deteriorates in any way, image the child. Remember, other than having cerebral edema and being at risk of coning, they are at high risk of intracranial bleeds, and that would put transplantation out of the picture. So once you've got a deterioration in your GCS, that child will need a CT scan. How do you protect the neurological system, and how do you manage a raised ICP? Basic principles apply. Head up at 30 degrees, sedate the child, don't overstimulate them. Avoid the benzos if you can. You probably should, because it's eliminated by the liver. We use morphine and fentanyl propofol as indicated. We also like dexmedetomidine, and that works quite well in keeping the children, what should I say, quiet, not restrained, but not agitated. Agitation leads to raised intracranial pressure some more. Don't fluid overload the child. Keep your sodium between 145 and 150. You could give hypertonic saline if you detect clinical features of rising intracranial pressure, but overall keep it in that range. Early dialysis will help you. Evidence for prophylactic anticonvulsants is poor, and we don't give that unless the child has fitted. We won't give them anticonvulsants. In a child that you suspect may have a urea cycle disorder, ammonia scavengers are available. So that's very rare, and these scavengers are difficult to come by. What about the lactulose and rifaximin in terms of treating those gut bacteria producing ammonia? Little supporting evidence in the acute setting. Lactulose, we actually at the transplant unit loathe in the acute setting, because if that child ends up being transplanted, you sit with a hugely dilated colon full of gas lying all over the abdomen, and you'll get an unkind word from the surgeon who transplants the child. So in the acute setting, best be avoided. In terms of treating acutely raised ICPs, like I've mentioned, saline, hypertonic saline, mannitol we often use, but remember it's contraindicated in severe acute kidney injury, and watch your serum osmolality. If it's more than 320, you mustn't use mannitol. Transient hyperventilation you could employ. What about hypothermia? We don't often use that, but certainly it's best to avoid hyperthermia. That's definitely bad. Indomethacin is started like the barbiturates as a last-ditch attempt to bring your ICPs down, but in terms of indomethacin, it causes bleeding and renal dysfunction, not utilized by us, and certainly not things like thiopentone. And remember, in a child that's doing very poorly, that does have a graft on its way, either in a living donor, confirmed fit living donor, or an organ offer, consider taking that liver out and keeping the child in theatre supported until you can put a new liver into them. Coagulopathy management, like Marisa has mentioned, this is a balanced coagulopathy. The procoagulant factors, factor 5, 17, fibrinogen, and all the others, are reduced, but so are the anticoagulant proteins like antithrombin, protein C and F. So it's a balanced coagulopathy, and you should not correct the INR unless the child is actively bleeding. Like Marisa has mentioned, the child's often relatively procoagulant, but when you have sepsis on board, they may actually tip them over into a bleeding state. So best not to fiddle with the coagulation system. You don't know which way you're going to tip them. Like you can be giving them FFP or cryos. If they're not bleeding, leave them alone. We also use factor 5 levels in INR as a prognostic indicator, as a sign of liver recovery. And once you've given products, it's difficult to measure whether this liver is making an attempt at survival or not. Vitamin K may be given, doesn't cause much harm. It's probably redundant after 3 days in any case. In terms of platelets, give it if it's less than 10. And if it's less than 50 and you're planning an invasive procedure, you may also give some platelets. Remember your stress ulcer prevention. The last thing you need is a GI bleed in a child that's coagulopathic. And always keep in the back of your mind the risk of TRALI. And once you've got established TRALI and ARDS, that child is too ill to be transplanted, probably won't survive a transplant. So that is a situation best avoided. You have to also prevent secondary infection. Remember, the liver is essentially a giant macrophage. with 500 other functions, and it continuously filters your portal drainage from the gut. And once it is dysfunctional, the odds of translocation and sepsis are radically increased. So these children are inherently immunosuppressed. So keep an eye out for sepsis. Look out for fevers, SIRS, although that's non-specific. CRP is generally an unreliable marker of sepsis, but trends are useful and do have a low thresholds for surveillance cultures. We do give all of them prophylactic broad spectrum antibiotics and antifungals exactly for this reason. And once the child's established sepsis, severe sepsis, again, that's a contraindication to transplantation. So we don't want to end up there. Selective gut decontamination is not recommended by the literature at the moment. What about nutritional support? These kids have a very high metabolic demand, and you should try and feed the gut whenever you can. In terms of protein requirements, we don't restrict them below 1 gram per kilo per day. That's not shown to be beneficial, but you definitely don't want to give them a high protein feed. We know that that will shoot your ammonia up. You may struggle in a child that's quite fluid overloaded to provide them with adequate calories. And TPN plays an important role there, and you shouldn't be afraid to start TPN if you think the child's going to run behind in terms of caloric requirements. Remember the core-specific therapies that Marisa has mentioned. She knows a lot more about this than I do. I just know that for these weird diseases, there's often something else you can do. Remember the viral infections. Don't forget, if you sit with an HSV, a CMV, and so on, there are antivirals that can make a huge difference in the early phases. But things like acute Wilson's, even though there are core-specific therapies, got an extremely high mortality rate without liver transplantation. But just bear in mind that there are other things that you could try if you've got an established cause. So what about listing for liver transplantation? This is an evolving decision-making process. That is a decision that is made throughout the day by the multidisciplinary team. It is not a simple decision to make. Like Reese mentioned before, some kids will survive without a liver transplant, some won't. And deciding and knowing which child will do what is the real difficulty of acute liver failure. Modern management, which includes liver transplantation, has decreased mortality from pediatric acute liver failure from 72% to 14%. So modern management includes all the supportive therapy that I've mentioned and transplantation for the correct indications, and that's where it gets tricky. So a multi-point assessment over time is critical. Multiple point sampling of all of your prognostic markers are crucial, and then making a decision as you go along. And the trends in these markers are much more important than an absolute value. So which signs do we look for at the bedside that's going to tell us this child's not going to do well? Well, the degree of liver dysfunction is often an indicator. So looking at very high failure to clot INRs, more than 10, factor V levels, less than 10, very high bilirubin levels, but these things may recover, but the trend of these factors are very important. Features of extrahepatic dysfunction, so renal failure is not a good sign. Patients that are in SIRS, and then we know that age makes a difference. Kids younger than 10, adults over 40 do less well, and then the etiology is important. The non-paracetamol, non-hepatitis A patients don't do as well. The acute Wilson's, the GALDs, the HSVs do particularly poorly without liver transplantation. Remember to keep an eye out for things that may preclude the patient from liver transplantation. So if you know that your child has pre-existing advanced or progressive neurological impairment, that would exclude them from transplantation. Patients with mitochondrial disorders, active extrahepatic malignancy, and then that tricky one that always gets diagnosed for me, HLH, that is a contraindication to liver transplantation. So how do we look at all of these prognostic markers and actually make a decision? Because in the end, it's a gut feel, but there isn't a lot of firm evidence out there for the pediatric population, but you've got to go with something. So we're going with the King's College Hospital criteria, which essentially look at these different prognostic factors and divides it between those that have overdosed on paracetamol and those that have liver failure from other causes. And it is listed here. I can, for the life of me, I have to look it up every time to make sure whether the child is in King's or not yet. But essentially what you look at are lactate levels, level of hepatic encephalopathy, your INR, and a creatinine of more than 300, because that would indicate to you the extrahepatic dysfunction. Age is also a factor, an issue that factors in there as a poor prognostic marker, as well as the duration of jaundice to hepatic encephalopathy. How long did it take the child to go from simply being jaundiced and a bit ill to becoming encephalopathic? And if it's more than 7 days, it's probably not a great sign. And then the Clichy criteria is another set of criteria that are used, especially by the Europeans. They like it, and they look there purely at the grade of encephalopathy greater than more at 3 or more, and a factor 5 concentration. And that differs between patients under or over 30 years. So that essentially at least gives us a point where we can say, okay, we now are within King's College criteria, we need a donor worked up urgently. But again, you're not going to just pull the trigger if the child is in King's College criteria, but improving. It is about trends rather than absolute numbers. So the role of transplantation, before transplantation, mortality was very high. After the introduction of transplantation, it's 11% at 21 days. So it's important that volume matters. In units that do more than 50 technically variant graft transplants, the outcomes are better. And remember, technically variant graft is essentially a graft that's not a simple whole size matched graft. It's a living donor graft, it's a split liver graft, it's a reduced liver graft. And then living donor liver transplantation has its additional advantages. It has got decreased cold ischemia time. It's a better quality graft. We know that it's got better long-term survival, and it will reduce your waitlist mortality because you can work up living donors at will, as opposed to waiting for an organ on the deceased list. So what happens if the child does get transplanted in the end? 1 year survival for a child that meets King's College criteria after liver transplantation is 70%. That is lower than transplantation for other causes, but remember the mortality of that child would have been very high. After 1 year, if the child survives to 1 year, the survival is as for any other cause for liver transplantation. So that child should be listed for status 1 listing early on. Don't know why it's doing that. And remember that our country does have access to a living donor program up here in Johannesburg. So just give us a call so we can get transplanted sooner rather than later. These are the different grafts that you can put into a child. I won't bore you with the technical aspects, but as a surgeon, I had to put one picture of a liver in at least to know what the options are. So you could just plug in a whole liver, there, number 1. Great, perfect. Rolls-Royce liver works well. The odds of you getting a pediatric sized graft in time is virtually 0 in our country. The piggyback technique is essentially a cable preserving technique of transplantation. Again, you need a whole graft. So you could split a liver. If you are lucky enough to have a donor that's young, pristine, you could split a liver and give the child a segment 2 or 3. A larger child may need a segment 4, 2, and 3. Or you can do a living donor graft, either a full left, a left lateral segment, or a full right, depending on the size of your child. What about auxiliary liver transplantation? That's a concept where you implant a partial graft from a living donor into a patient after doing a hemihepatectomy. So you keep the native liver, part of the native liver in situ, you replace a portion of the liver with a graft, and you wait to see if the child's native liver will regenerate or not. If it does, great, you stop the immunosuppression and the transplanted graft will shrivel away and your child will not need immunosuppression for life. If it doesn't, well, you've done your transplant, that will regenerate and the day is saved. Of note, technically very challenging. Doing a hemihepatectomy on a child in acute liver failure, bleeding from every orifice, is not easy. So it is not employed by us at the moment. If your child meets King's College criteria, they will get a transplantation with a full explant hepatectomy. So your patient qualifies for a liver transplant. What will happen then? Well, waiting times vary. Like I've mentioned, we don't have access to pediatric donors. Children rely on reduced grafts with high morbidity and mortality risks. So living donation is a real lifeline. Remember to monitor for futility. If you've got progressive sepsis despite treatment, invasive fungal infections, escalating inotropes, evidence of brain death or ARDS, unfortunately the ship has sailed and that child does not qualify for a liver transplant. Quickly, just to note that you do get things like an extracorporeal liver support system. It essentially is like dialysis for the liver. The evidence for it at this point is very poor. There's no survival benefit over plain dialysis, but in principle, they are working very hard on machines that do two things: detoxify the blood and then have some sort of synthetic function. So to detoxify, you need something that will bind lipid-bound toxins. So you will need albumin-based dialysis. To have synthetic function, you need a cell. And getting hold of enough cells that won't get destroyed by the system is difficult. But I've listed all of those machines. No evidence for it at the moment, but you never know where we will be in 10 years' time. That's a picture of just essentially what happens during MARS, molecular absorption and recirculation system. That's an albumin-based dialysis, and that is another system. There's no cellular component to this, so there's no synthetic function in these systems. You need liver cells for that to be performed. A last note on liver cell transplantation from my side. What about just infusing hepatocytes into that dead liver or half dead liver, and then maybe it can take over some of its function? Well, it is under investigation. The way in which you will have to infuse those cells will have to be into the portal system. So you can access the portal system through the umbilical vein in a newborn, which we never see, or you could access it through the inferior mesenteric vein, the SMV, or the splenic vein. You can infuse cells into the spleen or into the peritoneal cavity, but this is under investigation. And remember, if there's any chronic element, liver cell transplantation does not deal with portal hypertension, so it will not work in that setting. Infusing balls of hepatocyte into the circulation has got an inherent risk of embolization. And where you get those cells from are important. If you're going to get them from a pig, xenotrophic viruses are a real issue. And if you get it from hepatoblastoma cell lines, obviously there's a malignancy risk. So I've spoken about the supportive therapy now and about the role of liver transplantation. This is a chart that's useful to have. I'm not going to go through it on the non-transplant treatment of acute liver failure. And there's a lot of but essentially, these kids need to be treated by a unit that does a lot of it. So please give us a call and we will assist you. Thank you.
We did put together a little bit of a poll, and it basically just addressed people's exposure to acute liver failure and what they think is accessible to them. And I'm not sure if maybe we could just take that poll, put that poll up and see what everyone's baseline kind of approach and attitude towards this is. So we just had a couple of very basic questions, like have you ever recognized a condition that has required liver transplantation? Whether you are aware of any units in South Africa that offer liver transplantation. Have you ever referred a child for a liver transplant? Yes or no? There's a few more that go on below that. I just can't address them right now. I don't know what order we've put them in. Hold on 1 second. It's going back.
And Marisa, I'm just going to give another 1 minute because I do want to get to the questions. So I see we've got about, if we get to 100 people that answers, then I'm going to end the poll and we can share the results.
Perfect. And this is kind of what we have made our little bit of a passion project, is just increasing awareness to transplant, the fact that it is available, that it's accessible, that there are options. Because although a lot of these patients don't require transplantation, it is at the end of the day something that is necessary in, like we've mentioned, up to 10 to 15% of these patients. And you would like to provide or be able to provide your patients with all the options that are available, everything that you can.
Okay, great. So I'm going to share the results.
Okay, so that's interesting. Okay, so 71% of people have recognized a condition that requires liver transplantation. it's great to hear that 70% of people know that there is a unit that offers urgent liver transplantation. 70% have never referred a child for liver transplant, and it's not surprising, unfortunately, because we understand that there are obstacles or challenges, and that's what we'd like to address, and what we'd like to kind of help people navigate, so that these patients can in fact make it to us. So hopefully this is part of the solution in making us accessible and making it so that it's easy for you, or as easy as possible, to access us. So onto our pediatric hepatologist bread and butter, because if only 15% of patients with acute liver failure land up getting transplanted, who are the rest of the patients that are getting transplanted? And I don't know how to navigate the previous slide, but this is the diagnostic emergency. And I want people to understand that it is an emergency. So liver disease in the infant is an emergency. It's the largest population that will be attended to by a pediatric hepatologist. And importantly, these children do not look acutely ill. They may even be thriving, but diagnosing these can prevent life-threatening complications that are time sensitive. So patients who have hemophagocytic lymphohistiocytosis, so this is your HLH, your metabolic disorders, HSV or herpes simplex, your gestational autoimmune disease, and your biliary atresia all have interventions and therapies, targeted therapies that are available, and if implemented in a time-sensitive manner, can make a big difference in the outcomes in these patients. So I feel that I need to highlight that if you have a yellow patient, it is imperative that that patient gets attention, and gets attention immediately. So what is the definition of a jaundiced patient? So just to bring to mind that 60% of term and 80% of preterm infants do present with jaundice. This is mostly, well, it's attributed to physiological and is dominated by your unconjugated hyperbilirubin. And it's something that is easily addressed with phototherapy. Unfortunately, it also masks the need to assess and be cognizant and aware of the prolonged jaundice, which is jaundice that is present for more than 2 weeks in a term infant and more than 3 weeks in a preterm infant. And this is a trigger for investigation. If you've got pale stools and your diaper is staining yellow, and parents, this is actually a feature that parents are more aware of. So if you ask them what color the nappies are, they'll tell you that they're a deep yellow. But the problem is that with regards to the stools, 37% of health practitioners, so doctors and nurses, and 66% of parents actually cannot properly identify pale stools. And you have to use a stool card for comparison. So going to your patient and saying, what color are the babies? Are the baby's stools yellow? The answer is probably going to be yes. The really important question is, how yellow are those stools? And there are main causes of chronic cholestasis in children. There's the surgical causes, which include biliary atresia, which is our bread and butter, and the main cause of requirement for transplant in this country and everywhere in the world, and your choledochal cyst, which is eminently treatable with surgical correction. And then you have your medical causes. Here we also dominate with our hepatic infections, your parenteral nutrition associated, which is a diagnosis of exclusion, your mitochondrial and endocrine, which are actually more prevalent than you would think, as well as your genetic syndromes, which are on the rise in basically being identified and diagnosed, along with the advent of genetic testing being available. And then you've got your causes like galactosemia and tyrosinemia, which have a targeted therapy, and then your bile acid transport disorders. So what's important is that if your child is not well, they fall into a category which launches into an extensive investigation. But if the child is not unwell and is in fact thriving, you have to assess the stool color card. And this is the basic premise of a stool color card. So it's got normal stool colors, and you can see that there's deep pigmentation in those examples. And then you've got your light colored stools, and all of those are abnormal. So we tend to concentrate on the stool that is overtly abnormal, which is very pale. And we tend to forget that degrees of pale are still abnormal and require investigation. And of course, the primary pathology is biliary atresia, which is a progressive fibrosing cholangiopathy, which results in ongoing destruction of the bile duct. So it's not something static, okay? It's something that these patients are going to be dealing with for the rest of their lives. It accounts for a quarter of all neonatal cholestasis, and it is diagnosed via on-table cholangiogram or liver biopsy. And I feel I cannot emphasize this enough, not on abdominal ultrasound or HIDA scan. Those two are not nearly sensitive enough to exclude a diagnosis of biliary atresia. It has very poor native liver survival if it is diagnosed beyond the age of 2 months, because for the best results, a portoenterostomy needs to be performed in actually under 30 days, with 70% native survival if it's performed under that period, and 0% native survival if performed in a patient over 3 months of age. And if your patient your Kasai has been successful, if in a patient who's older than 3 months, you actually have to reassess your differential. Take home is, if a patient has pale stool and is jaundiced, you have to refer to a pediatric gastroenterologist for investigation. So our primary investigation is actually your liver biopsy, which is central. It's rapid, it's accurate, it diagnoses the biliary atresia in 88 to 97% of cases. We only perform a HIDA scan if the stool's ambiguous. So if you aren't quite certain if it's colored or not, or if liver biopsy is actually needs to be avoided. So if your patient is too coagulopathic, the patient is technically difficult, the patient is too small. These are the reasons why you might implement HIDA scanning. Ultrasound is useful in the diagnosis of choledochal cysts, so excluding other causes, which can be further investigated with an MRCP. So ultimately, ultrasound is supportive but not diagnostic. It can show you cysts of the porta hepatis, a triangular cord sign, small irregular gallbladder, which must be assessed in a fasting status. It can also show you polysplenia or asplenia, which supports diagnosis of biliary atresia with splenic malformation and situs inversus. But it is not diagnostic. So it excludes other diagnosis and supports the diagnosis, but is not diagnostic itself. The liver biopsy is, and shows expanded portal tracts with fibrosis and inflammation, with bile plugs and bile ductular proliferation. But ultimately, your operative cholangiogram is the answer, and it also allows you to intervene with your Kasai portoenterostomy. There are a number of physical findings in children with neonatal cholestasis, and assessing this is an entire talk of its own. So I've just gone briefly into a couple of these, and obviously there's dysmorphic features that are affiliated with certain conditions, both genetic and metabolic. There are associations with congenital infections. There are a host of signs that can lean towards a certain diagnosis, which can help you. The answer is to do targeted investigations, and this is tier 1, and this is something that all of us have access to. And if you look down the right-hand side there, you can see it's an FBC and differential, an INR, liver function test, glucose, alpha-1 antitrypsin phenotype, thyroid function tests, a urinalysis including reducing substances, bacterial cultures to exclude infection, and a fasting ultrasound, as I mentioned, to help either kind of lean towards or away from a diagnosis of biliary atresia. So these are all investigations that luckily the majority of us will actually have access to. And then associated with that is a general clinical examination that is also quite easy to conduct. So is the patient clinically ill? Are they well? Do they have dysmorphic features, any grossly dysmorphic features? Are there any cardiac lesions on cardiac examination, such as peripheral pulmonary stenosis in your allogeals? Is there ascites? Assess the liver and spleen size and consistency. Are there abdominal masses? And also the tone and vigor on neurological examinations. So this is something that as pediatricians, we can all perform, and it actually is incredibly helpful at being a first tier of investigation and signaling out the patients that are problematic. What is the second tier? And now we're getting onto things that are a little bit more extensive. And you can see that there are features that are linked to certain syndromes, and the syndromes and genetic causes are very extensive. The good news is that, well, that's not the good news. This is the testing that is affiliated with the second tier, and you can see that it's extensive and it's inaccessible. This is not something that every person is going to have access to. This is not something that everybody is going to be able to conduct, and it's not something that you should have to, because the good news is that your tier 2 aims to do a targeted evaluation in concert with a pediatric gastroenterologist or hepatologist. So once you've performed your primary investigation into your cholestatic infant, time is now to pick up your phone, call your hepatologist, and notify them that you have a child that requires more extensive investigation. Now, I know we said management of acute and chronic, but I'm going to just briefly, very briefly, touch on management. And there's an extensive profile to management. An important one is nutrition. So get your dietitian involved. We use our mid-upper arm circumference as an assessment tool to see how well they are. And the importance of this is that the better they are in terms of nutrition, the better they perform post-transplant, with an 8-fold increase of mortality linked to a poor mid-upper arm circumference. Our nutritional needs are extensive and include energy, lipid requirements, branched chain amino acids, and protein. In terms of medication, some of the medication you might come across is in terms of pruritic management. So you'll come across ursitan, your bile acid binding resins like your questrin, phenobarb, rifampicin, antihistamines, and naltrexone are all agents that are used in assisting managing the pruritus secondary to chronic liver disease. In the context of ascites, your furosemides, spironolactone, and your albumin in refractory cases, and octreotide in the context of variceal bleeding. Very rarely we use cholangitic prophylaxis, but if you're on cholangitic prophylaxis, you're being assessed for liver transplant because this is a risk factor for sepsis. And just briefly to touch on vitamin supplementation, obviously they all have fat-soluble vitamin deficiencies. So where do you start? So vitamin A, 5,000 to 25,000 units per day, or vitamin D, 500 to 1,000 international units per kilogram per day, and your vitamin E, 25 to 200 per kilogram per day, associated with your last, which is your vitamin K, which can go anywhere from every alternate week, twice per week, up to 10 milligrams a day. So just bear in mind that a lot of the vitamin supplementation that we use is often, if you look in comparison to the prescribed or suggested, is often subtherapeutic and will not get your vitamins up. But of note, all these children with cholestatic jaundice should be managed in conjunction with pediatric hepatology. Just remember that if you've got a child with ascites, it's a complication of chronic liver disease. It actually represents decompensation and warrants an expedited referral. And if you've got a suspected upper gastrointestinal bleed, please refer to a facility with access to a pediatric gastroenterologist or pediatric surgery who has access to endoscopy. So a lot of these patients should actually be contacting a pediatric hepatologist or a surgical team. Just of note again is our contact details, and I'm going to leave you there with our contact details up so that you can take them down. And I'll hand this over to the board now for questions.
Thank you so much. Sure, that was a mouthful and so comprehensive. So thank you so much for that. Guys can breathe a little bit after all of that. So thank you so much. That was really amazing and I think so informative. We've got quite a few questions, so we're going to take about 5 minutes just to try and get through some of them. So one of the questions in the chats is, do you make use of sodium benzoate for neurodetoxification? I think you briefly touched on it.
So we don't routinely use sodium benzoate for neurodetoxification. What we do use it for is in the context of your urea cycle disorders. So that is the application that we use sodium benzoate for, not routinely though.
Okay. Do you consider cross-country liver donor liver transplant for private patients? And can the surgeon be flown in for a liver transplant to other African countries like Namibia?
International, you mean? Cross-border South African?
So probably Africa, so like our neighbors, Namibia.
Right, so we've had that before, and yes, you can. The issue just becomes when a foreign national, to actually be listed on the deceased donor list, he would have to have permission from the Minister of Health, which is not an undoable thing to do. But often these patients come with living donors, and we've certainly transplanted children like that. So it is a doable thing to do.
Okay. Can you comment on liver transplant in children with genetic causes of liver failure?
So it's growing. So I think the list of patients who are excluded from transplant because of genetic causes is becoming less and less on a regular basis. I think this is through experience. I think what happens is a lot of these patients are being transplanted because a lot of them are difficult to diagnose in the acute setting, and they are getting transplanted and we're having success. So the list of patients who are actually being denied transplant because of cause is actually shrinking. So I think that's actually an evolving kind of thing. So hopefully shortly it will be available to pretty much everyone. So we do tyrosinias for sure. They need expedited transplant. A lot of those are your acutes, your galactosemias. A lot of them actually identified late, unfortunately, so they go on to require transplant. And your alpha-1 antitrypsins are also, a lot of them do land up ultimately getting transplanted. So genetic causes actually do make up a good proportion of patients who require transplant.
Okay, good. A question that I also have is one from Ruan. Have you done any transplants on kids from other provinces? And I know that when I worked in the Western Cape, definitely got some kids in, but other provinces?
Absolutely. When a child has an acute liver failure in a different province, logistically, it gets very tricky in getting the child stable enough for a transport. But we have flown children in, we've had them road transported, and our ICU team communicates very closely with the transferring team in doing it in a safe manner. But absolutely, I don't think there's a province where we haven't had a child from.
No, in fact, we're starting to develop almost kind of satellite units in a way. So for example, we've got 4 patients post-transplant now who are being managed in the PE area, 2 patients who are being managed in the George area. I think as people become more aware and more comfortable managing the patients, definitely. And just of note also is that another pet project of one of our intensivists is a retrieval team. So the idea behind this also is to send out a pediatric intensivist to fetch these patients, an intensivist who knows how to manage these patients, because transport is such an important part of getting these patients to us in a condition that will actually give them a chance. And it can be hours, and to lose that time is invaluable. So this is something we'd like to expand as well, is actually to create a retrieval team that is going to go and fetch the patients and bring them in.
And unfortunately, we've had, like you said, transport's so important. We've had kids coming from very far away that were managed properly and came here safely and were transplanted. And we've had very local children who arrived brain dead that were not managed properly. So it's really about how you stabilize the child and make it safe.
Okay, and then just one more question: state versus private. Do you do more private? Do you do more state? And there's been a couple of questions to ask whether their patients in state hospitals from other provinces would be able to access this program.
So we actually used to do more state than private, but we're evening out a little bit now with the advent of COVID. And there's a whole lot of factors that leaned into that. But in terms of acute, we actually probably do more state than private acute at present. And that's because of the hepatitis A component of it. In the private sector, we obviously are voluntarily vaccinated against hepatitis A, whereas in the state sector, it's not part of your standard immunization protocols. So we do see quite a few Hep A's, and that's the primary cause of acute liver failure of the state patients that we see. In terms of transferring a state patient out, it is logistically tricky, but it is possible. So the route that we've engaged in is to notify both the CEO and the MECs of the provinces. So it goes through CEO notification of the hospital involved, who then notifies the MEC of the province, and the MEC then goes to the MEC of Gauteng and comes to an agreement in terms of transfer. So we've had patients come in from KZN, we've had patients come in from Bloemfontein, and we've definitely had patients come in from Cape Town. We have a close relationship with them. So it's definitely possible. And I think the more we do it and the more we try to do it, definitely the more likely we are to actually get this working and to get it functional.
So I've just got one more question. So as a pediatric critical care specialist, acute liver failure has always been kind of one of those criteria where we will say actually in a resource limited situation, the patient won't make it into ICU. So then you often don't support them if they do become encephalopathic. So with this approach of saying that we want to transplant more of our acute liver failures and it is available, would you recommend that we actually relook those admission criteria, support these children, and like what would be the prognostic markers and the kind of timing that you would look at? How long will you support these children?
So from our side, I can say we say aggressively yes. So in our opinion, no child with acute liver failure should not be considered an ICU candidate, because like we mentioned, actually only 15%, and that's the higher end of it, are going to actually require transplant. The rest of them are actually going to survive just with medical support. So if you think about it, every patient that you take into your ICU, so out of 10 patients that you take into acute liver failure, into your ICU, at least 8 of those are coming out of your ICU with just medical support. And from the perspective of transplant, we will never ever say to you that the patient is not a transplant candidate, except in certain settings. And Fran touched on some of those, and it's usually patients who have like multi-organ involvement and patients who are rapidly progressive and have a contraindication or have imminent features of coning, or already have clinical features of coning. So there's absolute contraindications, but beyond the point of no return, there's actually very little that will preclude a patient from transplant.
Okay, I am going to quickly hand over to Mignon to just make a comment, and then Despina is going to handle the rest of the questions. Thank you so much.
Thank you. So firstly, just to say amazingly thanks to Team Donnie Gordon, to Marissa, to Francisca, Despina, and the whole team, just for your support and collaboration, to the Cape Town team. You guys really rock. I wish I'd had this webinar when I was training, and I'm delighted that we are recording at Mati, because I want to actually bottle it and dole it out in 5 ml doses from time to time. I think it's a brilliant teaching resource. And I think for me, what strikes me loud and clear is attention to detail. Now, as a nephrologist, I thought I was pedantic, but I think with these kids, you need to go even beyond that. And so definitely attention to detail, because that really saves lives, whether you're in Johannesburg or whether you're in the most remote part of the country. So I think that's really important. And then for those people sitting thinking this is very high-flying medicine, I think it's primary healthcare, and I know a lot of us feel very strongly about that yellow stool card. And gone are the days of 12 weeks is still okay to do your Kasai. I think there's definitely a lot of evidence saying it must be done in under 30 days. And I went to the Espegan Congress, where not only did I get COVID, but I also learned that 30 days is when you actually need to be getting stuff. So for those people working in smaller clinics, peripheral hospitals, definitely, as part of your vaccination campaign, ask the mom what's the color of the stool. They did a European survey, and only 30% of Europeans were asking what the color of the stool was. So brilliant, brilliant presentation. Thank you, guys. And thank you for teaching me lots of new stuff.
My turn, and we have 7 minutes. So I also have to say thank you, awesome guys, you make me so proud. So I'm going to just go through some of the questions in the Q&A, but I do want to reiterate what Mignon's just said, and I see one of the comments was from Akona, and this is how a lot of us feel. When we were training, we always thought the liver failures would die, and that was the patient that you wouldn't fight for in the M&M, but just go to the corner and die, and patient that never got ICU. And what's amazing is how this has totally changed, and we are fighting for these patients, and they are doing well. So I love the fact that Akona says, sadly, his patient died, but now he knows. So now he knows, and now he knows who he's going to advocate for, and now he knows who to phone. And I think that's the big thing. It sounds like you're going to get some phone call from Namibia, and I think the answer to that is fly the patient up for now, not the surgeon down for now, but that might change in the future. Am I correct, Fran? For now, fly the patient up. So let's go through some of these quickly. Yes.
You need a whole village to transplant these kids, so you would have to fly the entire team up to you, and then that would leave our country with zero capacity. So
Yeah. So look, we didn't, but we also have a lot of interventional radiology and a lot of other stuff. So for now, it's better that the patient flies up to us, and they are also part of the team, and it's not everywhere that they're available. So let's go through some of these questions. Reese, the first one's for you. How do you establish the diagnosis of autoimmune hepatitis when the liver biopsy is not an option?
So yeah, that's a difficult one. So the answer is you can't definitively make a diagnosis of autoimmune without a liver biopsy. So the liver autoimmune hepatitis is a fluctuating disease course. So are we talking about, and now I need to query back, acute or chronic, because the two are totally different. So your acute autoimmune patient is usually a patient who has got positive autoimmune markers. There are other suggestions based on family history. It's your patient who usually they fit quite a distinctive profile, and they usually fit a demographic profile as well. So it's your young teenage female. And unfortunately, in that context, you're not going to get a liver biopsy. All your liver biopsy is going to show you is fulminant necrosis. So in that context, if you have your elevated IgG, you have an increased total protein gap, you have positive markers, we treat them as autoimmune liver disease. In your chronics, usually you have a little bit more time available and you monitor the child, and essentially over time a lot of them do develop serological markers that are suggestive of autoimmune hepatitis, and at that time we actually perform liver biopsies to try and support our diagnosis. And to bear in mind, there is actually something also called seronegative autoimmune hepatitis, which is where you have no serological markers. And remember, your child is not an immune active individual often. So they don't pour out antibodies like your adults, which makes it very easy to make a diagnosis. So your child can also have an autoimmune hepatitis based exclusively on a liver biopsy. So we have a whole spectrum of disease, and I must be honest, it is a little bit nitpicky in terms of everybody has their own kind of like their own protocol that they almost stick to. It's with international guidance, so there are international guidelines that we follow. But a lot of the time it's a feeling. It's you go with a cluster of things that come together that gives you a concise picture of autoimmune.
So great, thank you. And my advice would be phone a friendly hepatologist, and they can tell you what they think. I think
for us even.
and yes, but I'm just saying we do, but we also do a lot of liver biopsies too. But yes, like you say, there's a criteria, a whole lot of things. So Visva mentioned, are there any markers used to predict early which patients will recover from acute liver failure and those that will progress to transplant? So I think you guys mentioned that, but sometimes we just don't know. Am I right?
Yeah. So, I mean, we would look at trends.
Yeah.
Does the INR come down without support? Do the factor 5 go up without support? Does your organ support requirements come down? Those are all good things. If you go in the opposite direction, you're probably heading for a transplant.
So Vesva, just so you know that we do the bloods quite regularly on admission. So they get done basically every 4 to 6 hours. So usually within 24 to 48 hours, we can see if a liver is going to recover or not. Am I correct, ladies?
Yes. And okay. The only thing of note is coming out now is there's a marker now called soluble IL-2 that's just come into South Africa this year, and that's associated with the indeterminate, and those just have a poor native liver survival. So patients who pop positive for very high soluble IL-2, those are patients who are probably in more dire straits than your average patient with liver failure.
Perfect. And then what would your advice, just 1 minute, what would your advice be in patients with pediatric acute liver failure secondary to herbal ingestion? Not really any different, right?
No. Same.
Correct. So once again, going back to the thinking that we got taught as years and years ago, I'm giving my age away, but we got taught that herbal intoxication basically disqualified you from anything because it was, bad. But now we do transplant those patients and we do give them the ICU care that we need. So if you've got a patient that's secondary to herbal ingestion, you need to contact us anyway. And then transplant criteria, you guys already covered those. What are your transplant criteria? You mentioned those in terms of the King's criteria and the other criteria. But this question says, do patients from Eastern Cape rural area qualify? Because Nokukanya feels that most of their patients do not qualify. So can you answer that?
That's a very tricky issue.
Yeah.
And I suspect it surrounds social circumstances and
Correct.
whether that family can cope with a transplanted child or not. And that can be a very difficult call. And I suspect a lot of kids never reach us because the clinician makes that call all by themselves, which I would discourage. I would recommend rather picking up the phone, asking for advice before we transplant any patient. There's a very stringent social assessment that is made, and the parents travel with the child to us, and we then have our social workers involved, psychologists, psychiatrists if needed, and make that call. If a child is not a candidate based on social circumstances, then that child would then be sent back and supported until either recovery or death. But often families that you think will not do well actually really surprise you. And often families with lots of resources do poorly. So it's not a question purely of financial resources. There are many other things that go into that equation. So rather ask for advice and err on the side of referral rather than making the call by yourself.